Hi everyone. So in this video we will be studying the surgery images. So first image is of retroperitoneal hematoma. The retroperitoneal hematoma, we have three zones and different management is required in each zone. First zone is midline retroperitoneum. It extends from the aortic hiatus to the sacral promontory and contents are aorta and IVC. And in this region, both the blunt and the penetrating trauma needs exploration. Then we have zone 2. Zone 2 is lateral retroperitoneum and it extends on either side from the renal hilum to the pericolic gutters and contains our kidneys and adrenal glands. And in this region, blunt trauma requires observation. Explore only expanding hematoma and penetrating trauma. If there is penetrating trauma, then we need exploration. Then we have zone 3. Zone 3 is pelvic retroperitoneum and it extends from sacral promontory and encompasses the pelvis. Content of pelvic vasculatures. Iliac vessels. Basically, iliac vessels are present in this zone. The blunt trauma, we will do external pelvic compression and fixation, and the penetrating trauma needs exploration. So, what we need to remember in zone 1, whether penetrating or blunt needs exploration. In zone 2 and zone 3, we will be exploring only if there is penetrating trauma. Okay. Then the next image we have is of Keher T tube. Keher T tube, this is the T tube put in the CBD. In case of CBD stone, and what is the technique used here? It is Burhin technique. Burhin technique for retained stone removal. Okay. Then next we have image of different procedures that are used in case of chronic pancreatitis. The first one image is of classical Whipples. In the classical Whipples, we will be doing the anastomosis with the liver, hepatico. Then is we will be doing the anastomosis with pancreas, pancreatico, and with the stomach, gastro, hepatico, pancreatico, and gastrojejunostomy. And then we have the Longmire transversal procedure. In the Longmire transversal procedure, it is also known as pylorus preserving Whipples. Okay, it is similar to the Whipples. The only difference is that here the pylorus of the stomach is also preserved. Here the pylorus was gone, while here the pylorus is preserved. Then we have three procedures. We need to remember the name and what is done in that procedure. The first one is Begar procedure. In the Begar procedure, the preservation is done along the C loop of the duodenum. We preserve the tissue along the C loop of the duodenum. Imagine like a beggar. Beggar needs something. So it says that please give me the C loop of the duodenum. Okay, how we will remember it. Then is phrase procedure. Fray, remember like fries. Fries are longitudinal shaped, so fray. Fray is head coring and longitudinal pancreatico-duodenostomy. Here the longitudinal pancreatico-duodenostomy is done. And then is Bernays. Bernays is just burn the head. Okay, Bernays is head coring only. So remember the three procedure: beggar, fry, and Bernays, and then is Longmire transfer. So classical Whipples. Then next image we have is of abdominal CT, and this CT is showing the interstitial edema of the pancreas with the homogeneous enhancement of the pancreatic parenchyma and mild inflammatory changes. So basically in this image, see, these are the two kidneys and this is the liver. Then this we have the pancreas. In the pancreas, the interstitial edema is there. Classical picture of the pancreatitis. Interstitial edema and inflammatory changes will be there. Then next image we have the points where the ischemic colitis. Ischemic colitis is more prone to occur. In the colon, we have the marginal artery of Drummond, and in certain areas the blood supply is poor, so it is vulnerable to ischemia. The first area is in the region of the splenic flexure on the left side, and what is the point here? Griffith's point. Then we have the rectosigmoid junction. In the rectosigmoid junction, it is Sudak's point. Sometimes we get confused that it was Griffith or it was Sudak. So how we will remember? Griffith point. G comes first, then comes the S. Okay, S, Sudak's point at the rectosigmoid junction. Then next we have the histological images. Histological images of the carcinoma. See, this is the squamous cell carcinoma of the esophagus. Okay, squamous cell, we will see the classical keratin pearls. Then next we have the small cell carcinoma. In small cell, there will be multiple small bluish cells. Okay, then next we have the adenocarcinoma. In adenocarcinoma, the glands will be there. The glands, hollow looking glands will be there. Then next we have the esophagus. In the esophagus, the classical squamous epithelium will be there. Normal slide of esophagus. This is normal slide. This is small cell. Then this is squamous cell with keratin pearls, and this is adenocarcinoma. Then next we have the image of, see, image here is given, and in this classically it is given that 4 into 5 centimeter Bosniak type 3 complex cyst. What is the most likely diagnosis? It is basically concerned with the kidney. See both the kidneys. Okay, in this kidney, in the right kidney, we have the blackish mass. What is the blackish mass? This is the angiomyolipoma. Black is due to fat, and lipoma, angiomyolipoma, contains fat. It gives the black appearance. This we have done also in the radiology images, similar images here. Then next we have the image of the amoebic liver abscess. In the amoebic liver abscess, we will have the classical double target sign. Double target sign will be there in the amoebic liver abscess. Then next we have the image of the midgut volvulus. In the midgut volvulus, first in the barium we will have the corkscrew sign, and in the CT image, in this image we will have the whirlpool sign in the transverse section. Whirlpool sign and corkscrew sign. Okay. Then next we have the sigmoid volvulus. In the sigmoid volvulus barium image we will have coffee bean sign. Coffee bean sign, and coffee bean will be towards the apex, will be towards the right side. Okay. Then next we have the steel pan sign. Steel pan sign in the transverse section. In the CT image, steel pan sign. Okay. Coffee bean in the steel pan. Imagine coffee bean in the plate. Okay. Then next we have the Nimura technique. Nimura technique is basically associated with the liver transplantation. So here what we do, this much liver is normal. Tumor resection, after tumor resection, this one liver is the remnant liver, and it is very less, so we need to hypertrophy it. Okay, so how we will hypertrophy it? We will ligate the portal vein. Okay, ligate the portal vein, then hypertrophy of the remnant liver will be there, and then the resection of the deportalized liver, this which was not with the tumor, that liver is resected. So we need to liver partition and portal vein ligation for staged hepatectomy. I'm sorry I said about transplant, but it is not about transplant. It is about the liver tumors. If there are liver tumors, then we cut the blood supply to the tumor one side, and the normal side we grow. And after the growth, then we do the hepatectomy. Okay. Then next we have the short bowel surgeries. In the short bowel surgeries, like after resection, there is short bowel, so there are many complications. So we do the surgery to elongate the short bowel. The longitudinal lengthening is known as Binacci procedure, and the transverse is known as step serial transverse enteroplasty. Then we have the duodenal hematoma. In the duodenal hematoma, we will have coiled spring sign. There was corkscrew sign. Corkscrew sign was in the corkscrew sign we had in the midgut volvulus. Okay. Then here we have the coiled spring sign. It is in the duodenal hematoma. This is the region of stomach, and this is the duodenum. Coiled spring sign, barium. On CT we will have the picket fence sign, and on MRI we will have the ring sign. This is X-ray image of toxic megacolon. In the toxic megacolon we can see the lumen of the colon is enhanced, Lumen of the clone is basically extended. It is more wide and there is loss of colonic ostration. It is straight and there will be lead pipe appearance. These cases are seen basically in the ulcerative colitis, okay, toxic megacolon. Then next we have the image of Rovsing sign. Rovsing sign may be elicited by palpating the left lower quadrant. This paradoxically causes pain to be felt at the right lower quadrant. Rovsing sign is basically seen in the appendicitis. In the appendicitis, we palpate on the left side, but the patient feels the pain on the right side. This is known as Rovsing sign. Okay. Then McBurney's point. McBurney's point is the classical point where the tenderness is felt in the acute appendicitis, and this is due to the pain elicited in acute appendicitis and due to the peritoneum involved. The McBurney's point, where is the McBurney's point? It is medial, between the medial 1/3 and the lateral 2/3, between umbilicus and anterior superior iliac spine. Next image we have is of carcinoma gallbladder. Basic, in the two we will get confused whether it is polyp or whether it is carcinoma. How we will differentiate? See, in the polyp we will have the margins defined, but here the margins are not defined. See, here the mass is extending beyond the margins, so it is the case of carcinoma. Next image we have is of cholesterol. Cholesterol is basically a condition in which cholesterol is high and there are cholesterol stones in the gallbladder. So the complete condition of this is called as cholesterol. There will be cholesterol stones, cholesterol polyps, and the condition is known as cholesterol. Next image we have is of HIDA scan. HIDA scan is used in case of cholecystitis and in case of biliary dyskinesia. HIDA scan basically demonstrate how the bile transfers its path. Okay, it will come from intrahepatic biliary radicals, then it will be going to gallbladder, and then is the CBD. So the structures will be defined by it, and in biliary dyskinesia, it will be abnormal. Okay. Then next we have the ultrasound image of emphysematous gallbladder. Emphysematous means air has come in it. Okay, due to air, bubbles will be formed. So bubbles, classical bubbles in the champagne glass like appearance. The sign is known as champagne glass sign. Champagne glass sign, emphysematous gallbladder. Then next we have the adenomatous gallbladder, adenomyomatosis. In the adenomyomatosis, we will have comet tail sign on the ultrasound and the pearl necklace sign on the MRI. Okay, pearl necklace and comet tail. The next image we have is of intraperitoneal bladder rupture. So what will be the history and what will be the image showing? In this, the person will give history of pain and difficulty in passing the urine. Plus hematuria will be there. Blood in the urine. Okay. So how we will identify? Here the retrograde cystogram is done. The dye is passed into the bladder. Then the dye is spilling into the peritoneum. So it shows that there is intraperitoneal rupture. Okay. This is image of Bosniak classification. Bosniak classification we did also in the previous image, but it was linked with the angiomyolipoma. So what is the classification? Type 1 is simple benign cyst. Okay, type 2 is benign cyst with the septation and minimal calcification. Means just septation is there. Then type 2b, there is septation, thick and nodular calcification in the wall. Thick and nodular calcification occurs in the wall. Then type 3, we have the complex cyst with more calcification and more septation. Then there is type 4. Type 4 is malignant lesion with large cystic component and irregular margins. So Bosniak classification helps in the identification of the cyst and how much is the chance of malignancy. Like in type 1 and type 2, they are 0% malignant. In type 2F, that is 5% malignant. In type 3, 50% are malignant. Type 4 are 100% malignant. Benign simple cyst, then we have the septation, then calcification, then is more septation and calcification, and then is malignant cyst. This is Bosniak classification of renal cyst. Next image we have is of bladder exostrophy. Bladder exostrophy, see this is the umbilicus. Below the umbilicus we have the bladder. So bladder here is exposed. It is not covered by skin and other tissues. It is basically defect in the development of the ventral wall. The ventral wall did not develop, so the bladder remained exposed. It is case of bladder exostrophy. Then next image we have is of hypersecreting adenoma. Hypersecreting adenoma in the thyroid. It is giving the appearance, the blackish appearance means the secretion here is more. Okay, so hypersecreting adenoma in the thyroid. So that was the first part of the video, surgery images. The next images are left, we will be covering in the subsequent parts. If you find this content useful, please do like my video and subscribe my channel. Thank you.